started with Grand Rounds today. Welcome, everybody. I hope everybody is staying warm and safe on this snowy, lovely February day. We're delighted to have our own Dr. Luke Hillman give Grand Rounds. And to introduce Dr. Hillman, we have Dr. Michael Lucy.
Well, thank you very much, Lynn. It gives me great pleasure to introduce Luke to our audience. Many of you will know Luke. Luke is from Mequon, Wisconsin, and he received his undergraduate degree in biology and the history of science from UW-Madison. And he then stayed for his MD degree. He graduated in 2014 and was elected AOA. He then moved south to Chicago for his internship and residency at Northwestern. Now, Northwestern is the National Center of Excellence and Innovation in Disorders of the Esophagus. And while there, Luke found his calling. And then he returned to us in 2017 as a GI fellow. While a fellow, he completed the capstone program in clinical research. And we were fortunate to recruit him to our faculty in 2020. He joined our esophageal group, which Eric Gamnitz had started, and which also includes Luis Lamelli. There are two outstanding nurses in the group, in Holly and Heidi, and they work in close multidisciplinary arrangement with otorhinolaryngology in a true multidisciplinary clinic. Together, they have helped us move to the forefront of investigation and treatment of emerging disorders such as eosinophilic esophagitis, and they have introduced new forms of investigation that Luke is going to explain to us today. So this is a talk which I think will present new material to many of our viewers and listeners. Luke is the co-author of 11 peer-reviewed publications. So it's with great pleasure that I ask Luke to give us his talk, which he has entitled Updates in Esophageal Dysphagia, Taking a Small Bite of a Complex Problem. Thank you very much, Luke.
Thank you so much, Dr. Lucy, for that kind introduction. And thank you, everyone, for being here this morning. If you haven't already, please just take a moment and type in your code so that you can get credit for today's lecture. And in case my nurses are listening, I do have to give a shout out as well to Karen, who's my personal nurse. So as Dr. Lucy mentioned, my talk today is titled Updates in Esophageal Dysphagia. There are no conflicts of interest to disclose today. And so when I was asked to give Grand Rounds today about such a broad topic, it really had me reflecting about how my thought process has evolved about esophageal dysphagia and patients with swallowing complaints. Now, this is tongue-in-cheek, but as a medical student, I couldn't tell you the difference between dysphagia and dysphagia. And to be honest, I'm still not sure at this point I know if there's a different way to pronounce them. And something that I think the internal medicine residents can appreciate is, as a resident, all I really cared about was someone aspirating or not aspirating. You'd wait for the speech swallow study to come back, and you'd want to know, do they need nectar-thick, honey-thick liquids, or can they go home and eat whatever they want? Now, as a GI fellow, that thought process didn't really change too much. In a very inpatient-heavy fellowship training program, I would get a call about someone that can't swallow, and I'd go, do they need a G-tube or do they not need a G-tube? If they didn't need a G-tube, that was something that could be worked up as an outpatient. We don't really do manometry as an inpatient. But now that I'm the doctor that's seen these patients in an outpatient clinic, I've really come to understand and appreciate that this is a much more complex problem. And just like my thought process has evolved through my training, so too has esophageal diseases, particularly relating to people that have difficulty swallowing. We have new diseases like eosinophilic esophagitis. We have significant advancements in our diagnostic testing, such as high-resolution manometry. And just like every other field of medicine, we have brand new ways to try and treat these people. So I hope by the end of this talk, you can have a glimpse of what we're doing within our esophageal clinic, how we're managing these patients for something that really has become quite complex and nuanced. But I also hope you can leave the talk today with some insights and framework about how to approach a patient with dysphagia. So the objectives for today are first just to summarize the burden of dysphagia on patients' lives. Then give you a framework about how to evaluate patients with undifferentiated dysphagia. And lastly, really focus on esophageal dysphagia. That's my area of expertise. talk about structural or obstructive causes of dysphagia, and then finish with esophageal dysmotility and talk about our Chicago classification of motility disorders and talk about this new technology called Induced. So to begin, dysphagia is really, really common. It's highly prevalent. In this survey of 33,000 Americans, 1 in 6 Americans reported experiencing dysphagia at any point in their life. What's important to note in this study that only about 50% of those ever sought care for their problems. And most often when they do come in, they start talking about it with their primary care doctor. But these people aren't just coming to GI clinic or their primary care clinics. These people are spread out through all the medicine subspecialties because oropharyngeal and esophageal dysphagia are associated with so many other comorbidities, from asthma and allergy that might be linked to EOE, to scleroderma and rheumatoid arthritis for people that are going to have esophageal motility disorders. So these patients with dysphagia are in your clinics. It's just a matter, are we recognizing them? And dysphagia really impairs patients' quality of life. This is not just about are people getting enough calories or losing weight, but patients with dysphagia have impaired mental health. And this makes sense. When you and I decided to go out to eat, or maybe in the pre-pandemic times, we weren't just thinking about the calories or the nutritional benefits of what we're eating. It was about spending time with friends and family. I have a number of patients that don't go out to eat anymore. In fact, I talked to a young man in his 20s who's afraid to go out to eat with his coworkers or his friends and family. They ask him, why aren't you eating that? Why do you eat so little? He's too afraid that if he eats something and gets stuck, he's going to run to the bathroom and throw it up. Now, it's not just about how severe patients' disease is. We know that symptom severity is independent of disease severity. And that has to do with this anxiety and hypervigilance associated with swallowing. In this study, they looked at patients with motility disorders, at which time was classified as major and minor. Major just means a more severe disease. And they had them complete the esophageal hypersensitivity anxiety score. And what you can see is that patients that had high anxiety, higher scores, experienced much more severe dysphagia symptoms as measured by their DEDQ score. And that was true for the people that had minor diseases and those that had major. And so it's really changed our framework and thought process when we're evaluating patients with esophageal diseases. It's not just about that esophageal vent there in the middle. It's not just about how narrow their esophagus is or how severe their achalasia is. But we have to think about the patient as a whole. We have to think about their personality traits, the hypervigilance, the anxiety, acting as mediators of that event that then changes the patient's response. It's their perception of how bad their symptoms are. And all that ultimately leads to the impairment in quality of life. So now that we've talked about how prevalent dysphagia is and how it can impact patients, I want to talk about my initial approach to dysphagia. So just like anything in medicine, the most important first step is taking a medical history. When someone comes in with undifferentiated dysphagia, I ask them a lot of questions. I ask them how long it's been going on. I look at their medical history for different comorbid conditions. Do they have Parkinson's and I'm worried about oropharyngeal dysphagia? Or does someone have scleroderma and I'm thinking about some motility disorder? And I really try to break down the type of symptoms that they're having. I don't just say it's trouble swallowing, we'll move on, but I try to ask them about other things. They have drooling, coughing, dysphonia that I think about more oropharyngeal dysphagia. Are they having heartburn or regurgitation? Are they pointing in the middle of their chest? It makes me think this is more of an esophageal problem. Now, the important thing, and this is especially for people that are, in their training, is don't take a patient's at face value for the words that they're using. I see a lot of people come in and they use the words, I'm vomiting food back up. But when you pin them down, what they're really trying to describe is food getting stuck in their chest and then they're regurgitating it back up. But if you just take someone at the value of vomiting, you're going to start working them up for the wrong problem. You're going to start looking for gastroparesis, gastric outlet obstruction, cyclic vomiting syndrome. Similarly, people will say, I'm choking, and I really try and pin them down on that. Are they turning blue? Can they not breathe? Do they need the Heimlich? That food's going into their airway. Versus people that feel like they're choking, but they just are having the sensation of esophageal stasis. And when you're taking that history, just remember that the localization where a patient tells you they feel like things are sticking is not always that reliable. And that has to do with the fact that there's poor correlation between the sensation of stasis and the true location. And we think this has to do with the fact that patients experience this referred sensation. We see this often in patients that come in with food impaction, which I'll talk about in a little bit. We go into their scope, we see food lower down in the esophagus, but the patient, when they're talking to them, is pointing at their throat. And in the study on the right, this actually came out of our speech pathology department here at UW with a lot of data from our dysphagia clinic. When they looked at patient-reported location, where the stasis was in on the esophagram, you can see that both for pharynx and cervical esophagus, that correlation was quite poor, never even reaching the threshold of 50%. And lastly, just because someone has one condition, esophageal or oropharyngeal, doesn't mean that they can't have another. So don't get myopic and don't look for something else. So when someone comes in and you're taking that medical history, if someone tells you that, gives you the story that think it's oropharyngeal dysphagia, the best test to start with is always a speech swallow study. Alternatively, if they give you the perfect story for esophageal dysphagia, food sticking in the middle of their chest, they have bad heartburn, they have allergies, asthma, the next best test is always an upper endoscopy. But I think where things get tricky is when patients can't give you the perfect story, but they have features of both. And where is the right place to start? Well, a perfect example is this patient I saw just a couple weeks ago. She's 79 with a history of multiple CVAs, who has known oropharyngeal dysphagia. She has dysarthria from her strokes, but she's also had a Schottky's ring that needed dilation back in 2017. And she's come to our clinic with recurrent aspiration and choking sensation, and her providers are wondering, could her esophagus be playing a role? Well, I looked through her history and she had just had a swallow study 3 months prior, and it was noted to have aspiration. So I thought, I think we're done here. She's having recurrent aspiration because of her strokes and her oropharyngeal dysphagia. But then with talking with her and looking at her chart, she was scheduled for an endoscopy with me in 2 weeks. And I was like, I'm not really sure we should proceed. That's an invasive test. She's somewhat of a frail lady. I worry that we could do more harm with this endoscopy than good, since we have another answer. Well, this is the type of patient that's perfect for our multidisciplinary dysphagia clinic. It's a clinic with GI, radiology, and speech pathology. Patients get a speech swallow study and a one-on-one session with our speech pathologists, followed by an esophagram, and they meet with one of the GI providers. And my patient's esophagram is on the right. And what we found is that she had very severe esophageal motility. You can see just stasis of the barium all the way up through her esophagus. And so I thought her esophagus very well may be playing a role in her issues with recurrent aspiration. And now we're going to work her up for that. So this is a perfect first step for patients that have unclear symptoms, maybe for the older patients that you don't want to do invasive testing. And similarly, if you have a poor endoscopic candidate, patients with a severe cardiopulmonary disease, or people that you're not really sure what to do first, the dysphagia evaluation is a very good first step, and it really gives us a roadmap of both their oropharyngeal and esophageal dysphagia. So if you have anyone that you're not sure where to start with, send them to Dysphagia Clinic. We're happy to see them. An important note, though, is that there are some limitations with esophagram. We see this time and time again in our clinic, that patients are labeled as having dysmotility on esophagram, when really it is a poor tool to screen and diagnose for dysmotility. And that has to do with a lot of inter-observer variability. The radiologist, when they say dysmotility, we don't really know what that means. And often they'll label something like tertiary contractions, which are just little spasms of the esophagus that happen independent of swallowing, as dysmotility. And on the right, you can see the table that looked at the accuracy of esophagram using high resolution manometry as our gold standard. And you can see that the sensitivity and specificity of esophagram was quite poor, ranging from somewhere between 50 and 69%. Even for something like achalasia that you would think would be pretty evident on esophagram, only has a sensitivity of 39%. So as many of you know, once you label a patient or give the patient a diagnosis, it can be very difficult to undiagnose them. So just be careful when an esophagram says dysmotility. Really what that means is they need more evaluation. They need to be seen in GI clinic for further evaluation. So now that we've kind of talked about a framework about how to approach a patient with coming in with dysphagia, I really want to spend the rest of my talk focusing on esophageal dysphagia, because that is my area of expertise. Just like an undifferentiated dysphagia, when someone has esophageal dysphagia and I'm taking a history, I want to know what they're having difficulty eating. When someone tells me that they're having solid food dysphagia, my first thought is that they have some sort of structural or obstructive cause of dysphagia. Most often that's something like GERD or eosinophilic esophagitis, but you can see some other rare things like cancer, radiation strictures. But when someone tells me that they're having problems more with liquids, that immediately raises my suspicion for some sort of esophageal motility disorder. regardless of what I think is the problem, the first step is always to start with an upper endoscopy. An upper endoscopy gives us so much information. So you can see on the left there, that is a photo of someone with eosinophilic esophagitis. At the bottom of the stricture, we're seeing a stricture, and you can see these rings of the esophagus that we call trachealization, very classic. On the right is a patient with achalasia. Well, you might think that the esophagus would look normal in a motility disorder. Something like achalasia, you can see profound dilation of the esophagus and stasis, and that's exactly what we saw in patients. Let's just focus a little bit more on those structural causes of dysphagia. GERD or peptic strictures historically have been the leading cause of esophageal strictures and dysphagia. And that just has to do with the fact that GERD is highly prevalent. In this study that looked at the rates of GERD among Americans from 2006 to 2016, you can see that one, it's highly prevalent and that there's a slow and steady increase. The reason that I said historically the leading cause of strictures is that there is a declining incidence of strictures related to GERD, and that has to do with the efficacy of proton pump inhibitors. Proton pump inhibitor use is pretty ubiquitous. And in this study, you can see that the use of it was up among almost all age groups. However, you do see there at the end that in some age groups, the use is actually going down. And I think it has to do with this. I think the lay public as well as providers have become more keen and more aware or concerned about the use of chronic PPI use. I think a lot of these concerns are valid, but I think there's some caveats to that. A lot of it, this whole topic probably requires its own talk that really requires you to look at each individual study, the biases of the study and limitations of the study. But one of the concerns that we have in the GI world is that patients that really benefit from PPI use are being taken off of PPIs. For example, this is an 80-year-old gentleman I saw for endoscopy. He'd had a history of esophageal strictures, he has a large hiatal hernia, and he was taken off his PPI and put on an H2 blocker. Unfortunately, a couple months after that switch was made, he developed severe dysphagia, weight loss, and this is what we found on endoscopy. There really are a group of people that really need PPIs. And it's important to remember that H2 blockers are not the same thing as PPIs. And a lot of this data really predates any of my training, because when PPIs came out in the late 1980s and early 1990s, the head-to-head trials were pretty conclusive. PPIs are better than H2 blockers. In the study on the right, you can see the rates of esophagitis healing at 6 months for patients that were treated with omeprazole, almost 100%, versus only 50% that were receiving H2 blockers. Similarly, when you look at dysphagia relief rates, about 90% of the people in the omeprazole group felt better, whereas only about 40% in the H2 blocker felt better. And when they looked at the need for dilation or stretching the esophagus to open up those strictures, PPIs were associated with a lower need for dilation and fewer dilation. So H2 blockers are not the same thing as PPIs. At the beginning of this year, the ACG released a statement on the management of GERD. And at the bottom of it, they had a long conversation and topic about chronic PPI use. And I want to walk through, because this is what I think about when I'm approaching my patients. First, the most important thing to realize is that PPIs are the most effective medical treatment for GERD. They're much more effective than H2 blockers, and I hope the last page proves that to you. But they do note that some studies have identified these associations with long-term PPI use and numerous adverse reactions. But it's important to remember that there are limitations to these studies. These are observational studies, and therefore these do not establish cause and effect. I think we all remember from epidemiology class that observational studies really are hypothesis-generating studies, not hypothesis-confirming. And when we actually look at these associations, they're quite weak, with odds ratios of less than 2. And really in the only high-quality study, which the citations are on the bottom if you want to look it up for yourself, really these other associations were not seen, other than a small risk of intestinal infection. And this study was a randomized controlled trial, patients that were being put on blood thinners that were randomized to PPI or no PPI and followed for 3 years. Now that's not 15, 20 years of PPI use, but that's probably one of the best studies that we have. And this is often what I cite to patients when I'm talking to them. But the authors of the ACG guidelines do note that they cannot exclude the possibility that PPIs might confer a small risk of adverse conditions, but that the well-established benefits really outweigh theoretical risks. And again, we're talking about people that have an established condition. So when I'm approaching PPI use in my patients, the first thing that I consider is what is the indication for PPI use? Is this someone that has bloating, generalized abdominal discomfort? Or is this a patient that has EOE or severe reflux esophagitis, where PPI is really indicated? Next, I ask myself, is there an alternative treatment? Is there something that I can use that is not a PPI? For example, the algorithm for dyspepsia has PPI as a first-line treatment, but we can use other things like tricyclic antidepressants or prokinetic agents. And if I'm seeing a patient that's already on a PPI, I ask myself, can I reduce the dose? Can I stop it altogether? It really depends on what we're treating them for. But after I've gone through that exercise with the patients, I have a long conversation. We just discuss the risks and benefits. And just like in anything in medicine, I think the most important thing is that I make a shared decision with the patient. It's not me telling them what they're going to do. I let them make a decision based on the information that I provide them. And this is something that I often do in patients with eosinophilic esophagitis. These are young patients, 20s and 30s, that PPI is effective for them, but we have to make a decision. Are we going to continue them on this long term? Which leads me on to the next topic of EOE. EOE is probably the #1 reason we're seeing patients in clinic for dysphagia. And as a reminder, EOE is a chronic allergy immune mediated disease of the esophagus, and it comes in 2 different phases. We think that it starts as this inflammatory phase where you get recruitment of eosinophils into the esophageal mucosa. Over time, that leads to esophageal fibrosis, scar formation, and stricture development of the esophagus. That's when people really develop their dysphagia symptoms. And risk factors are males, people with other atopic conditions like allergies, eczema, asthma. And we see it much higher in a Caucasian population. And these patients almost universally present with dysphagia. In this study, they found that somewhere between 60 and 70% of patients, their primary complaint is dysphagia. What's interesting to note, though, however, is that about 25% of patients will have EOE kind of masquerade as reflux, or they'll describe heartburn, regurgitation as their primary symptom. And when we're treating EOE, like I had mentioned, the first-line treatment is often very high doses of PPIs. For people that don't respond to PPIs, are intolerant, or don't want to be on them, we do other things like topical corticosteroids, where they swallow a steroid, or an elimination diet. Endoscopic therapy is really important for these patients as well. When we dilate their esophagus and strictures, that really can improve their dysphagia symptoms. And our treatment is really targeted toward histologic remission, very similar to what we're doing in patients with IBD nowadays. We know that symptoms don't always correlate with inflammation, but we want to keep that inflammation at bay. And often relapse is common if we would withdraw medications. And I already told you, we're seeing a lot of EOE. Well, the incidence and prevalence of EOE is rising. And this study goes back to 2012, but I can tell you that this trend has definitely continued. And with that rising incidence and prevalence of EOE, EOE has now become the leading cause of food impactions. As I had mentioned, peptic strictures or acid-related strictures are going down, and we're just seeing more and more of EOE. And what are food impactions? Well, this is something that I can tell you strikes fear in the heart of all of my fellows. Food impactions are probably the #1 reason that we get called in the middle of the night. And unless you're an ER doctor or a GI doctor, it's something that you may not even be aware of. But it's not just about us getting called in the middle of the night. This is really a traumatic and uncomfortable experience for patients. So what is a food impaction? That's a picture of it. Well, a food impaction is a soft food ingestion resulting in complete obstruction of the esophageal lumen. Patients are unable to tolerate liquids or secretions. And these patients actually come in with plastic bags spitting up their saliva. This is really, really a scary event for a lot of people. The majority of patients, about 75, ultimately require endoscopy for us to either push the food into their stomach or pull it out. But this is an emergency because of the risk of pressure necrosis and esophageal perforation. This is one of my patients that had an esophageal food impaction that was managed at another facility. And while they were trying to push it through, she unfortunately developed a spontaneous esophageal perforation. And you can see those arrows pointing to her pneumomediastinum. She unfortunately needed emergency surgery. I see esophageal food impaction as a critical event in the lives of patients with dysphagia. For patients that have established esophageal disease, this is preventable with appropriate medical and endoscopic therapy. We can prevent this from happening. But for other patients, this is their first time they've ever come into the emergency room or ever been seen for dysphagia problems. This is our opportunity to intervention. We should get these patients established in our clinics, and long-term management of them can really improve their quality of lives and improve their swallowing symptoms. So just like I mentioned, that the rates from EOE are going up, but all causes of food impaction are going up. And when we look at our data at UW, going back to 2017, we're seeing somewhere between 70 and 80 food impactions per year. But what we found looking at our data and from the emerging literature is that we don't do a very good job when patients come in for food impaction and when they leave. There's lack of formal guidelines that really leads to heterogeneous care after food impactions. And in a study that we published last year, we found that empiric treatment with PPI can mask the diagnosis of empiric treatment with PPI can mask the diagnosis of EOE at follow-up. We were not taking biopsies during our food impaction endoscopies, putting them on PPI, and they'd come in and we'd say things look normal. Well, that can have implications long-term because we don't know what we're treating. Other literature in our own data also shows that about 50% of patients are lost to follow-up after food impaction. And all of this matters is because these people will continue to go on to have difficulty swallowing after this event. Additionally, lack of follow-up has been associated with food impaction. So how are we doing here at UW? Well, we have a loss of follow-up rate of around 44% among patients with food impaction. And we found that patients that do not require endoscopy, so they're given some medication like glucagon, they have a much higher rate of loss to follow-up than those patients that don't have or that do get endoscopy. And I think there's this misconception that non-endoscopic resolution signifies some less serious disease. And that data is, I think that's just not true. When we look at the people that do come in, about 93% of those patients have some significant finding on endoscopy, like esophagitis, EOE, or some stricture. And when we look at the recurrence rate among these groups, there's no difference in recurrence rate for food impaction between the people that get endoscopy and those that don't. We can do better. And that's why we developed the esophageal food impaction order set in collaboration with the UWED. We have some specific goals. First, we wanted to standardize and simplify care in the emergency room. So everybody's going to get the same treatment. They're going to get glucagon. Next, we want to expedite care to the outpatient GI world. And that's going to be done by creating an automated referral to GI clinic. I think we all know that there's a lot of hoops to jump through from the outpatient world to specialty care clinic. And we want to eliminate those hoops to jump through. And lastly, we want to improve patient education on esophageal disease and food impactions. If you've ever had conscious sedation, you probably don't remember anything from that day. Most of these patients don't either. So we now auto-populate their discharge instructions so that when they go home and wake up the next morning, they can read it and understand why it's important for them to come back. And our ultimate goal is to remove barriers to follow-up, improve patient experience, and improve their outcomes. And we're excited to announce that this launched at the beginning of this year. We've seen that it's been used a handful of times, and we're going to study this and see if this is really an effective tool to get patients into our GI clinic. Now that we've talked about the most common structural causes, I want to finish the rest of my talk with dysmotility, esophageal dysmotility. But this would not be a talk about esophageal dysmotility if I didn't mention Sir Thomas Willis. He first described accolage in 1672 when he treated a patient by sticking a sponge onto the end of a whalebone, shoving it down the guy's throat to relieve the obstruction. Well, I'm happy to say that we've come a long way since then. And we've also come a long way since traditional manometry. This predates my training, but a traditional esophageal manometry was developed in the early 1960s. And it was pretty basic. We just had 5 pressure sensors across the esophagus and lower esophageal sphincter, and it measured pressure. But with the advent of traditional manometry, we were able to begin understanding about what was going on when patients swallowed. But in the last 15 years, and with new technological advancements, we now have high resolution manometry. And it's pretty exciting. We now have 36 pressure sites compared to 4 or compared to 5 that span the entire esophagus. And using computer software, we can take that information from our manometry catheter and create these beautiful pressure topography charts. This has really changed how we classify and define esophageal manometry. And this was first described in the Chicago classification. As Dr. Lucy had mentioned, most of this data comes out of Northwestern, where I'd done my internal medicine training. And the first description of the Chicago classification was in 2007, but just last fall, they published version 4.0. In order to go through some of those nuances about how it's changing how we're practicing, I think it's important to understand what you're looking at when you see esophageal manometry. So first and foremost, when you're looking at the esophageal manometry graph, the x-axis is time. The y-axis is the length of the esophagus. And what you're going to see are some important landmarks. You're going to see the pressure at the upper esophageal sphincter, the pressure at the lower esophageal sphincter, and everything else in between is the pressure generated by the esophageal body. And this is like a weather map. The brighter the red, the higher the pressure, the deeper the blue, the lower the pressure. But because we have all these pressure measurements, we are able to use computer software to calculate some very important key metrics. And the most important metric I want you guys to understand or take away from today, because it really impacts how I look at manometry, is the integrated relaxation pressure, or IRP. And that really just tells us how well the LES, or the lower esophageal sphincter, is relaxing. Other important metrics are the distal contractile integral, and that just tells us how strong or weak is the esophagus contracting. And lastly is the distal latency. That tells us if you follow this dotted line down, from the start of the swallow to the peristaltic wave getting to the bottom of the esophagus, how quick does it happen? If it happens too quick, that can be consistent with spasm. And as I mentioned, we have these new criteria with version 4.0. There's been some major updates, things that I'm passionate about, and hopefully you can understand why it's really changing that we can treat patients better. So we no longer classify disorders according to major and minor disorders, but we now define them as disorders of EGJ outflow, with EGJ standing for esophagogastric junction, and disorders of peristalsis. And again, the delineating factor, the first branch point, is that IRP that I mentioned. We now have more stringent criteria for some of our diagnoses, which we'll get into. We've made some changes in our standard manometry protocol, which I won't bore you guys with. But lastly, that there is a strong emphasis now placed on clinically relevant symptoms. The authors were concerned that with prior iterations, we are potentially overdiagnosing and overtreating patients with quote unquote motility disorders. Here at UW, we have open access manometry. We get referrals from our pulmonary colleagues, from ENT, rheumatology, and it's important to note that when we're interpreting these manometries, we do our best to try to incorporate clinically relevant symptoms. So when we're seeing someone and we don't have the clinical context, it's important that when you get those results and take them back to the patient, that you incorporate what the patient is experiencing. I equate this to when you get a CAT scan back and the radiologist says correlate clinically. So this is the Chicago classification. This is our algorithm about how we interpret manometry. And as I mentioned, the first most important branch point is the IRP. Is the lower esophageal sphincter relaxing normally or abnormally? And I want to start by talking about disorders of peristalsis. These are patients that have a normal IRP or their LES is relaxing normally. And we'll start by talking about the hypomotility disorders. The first one is absent contractility. You don't need to be an esophagologist to understand what this is showing. Essentially, you don't see any contractions in the esophageal body. This is often seen in patients with GERD or often with connective tissue disorder, and it raises our suspicion for something like scleroderma. The other common condition is ineffective esophageal motility. Some diagnostic criteria have changed with the newest iteration. This is the most common abnormality that we find on manometry. When it comes to treating these patients, unfortunately, we really don't have any data on pharmacologic therapy. Most of our treatment revolves around reassurance. We talk about dietary modifications. We talk about taking smaller bites, alternating solids with liquids. And if we think that they have underlying GERD, we'll try to treat that. As I had mentioned, ineffective motility is one of the most common things that we see. And we often find it in patients that are being evaluated for anti-reflux surgery or fundoplication. And our surgeons are often very worried when they find this, that patients are going to develop dysphagia after a fundoplication. Well, as I mentioned, we've learned to do a lot of neat things with manometry. And we've learned to do these what we call provocative measures, one of which is called multiple rapid swallows. And we do this routinely in our manometry now. And what it is we have patients take 5 rapid sips. And what that does is it evokes a reflux within the esophagus to have a strong contraction. Some patients we see it and some we don't. And what we call esophageal reserve is when patients have that strong, vigorous contraction. If it's stronger than their normal swallows, that can actually be protective against post-operative fundoplication. So our surgeons will look at this data and it will really inform them whether they should do a fundoplication? And if so, should they do a partial wrap? Should they do a full wrap? So this is one way some of our new measures with high resolution manometry are really changing what we can offer and how we're treating patients. I'll move on to the hypercontractile disorders. The first one being distal esophageal spasm. This just means that patients are having a very rapid contraction, which often impairs bolus transit down the esophagus. The other one is hypercontractile esophagus. This used to have the term nutcracker esophagus, which is no longer used, and other people maybe remember hearing about jackhammer esophagus, but we now call it hypercontractile esophagus. These patients typically present with dysphagia and non-cardiac chest pain, and the exact etiology is unclear. We don't know if it's from GERD, impaired inhibitory pathways, but treatment often includes optimizing GERD therapies, trying smooth muscle relaxants, and actually the first thing I often try is peppermint oil. And you're probably thinking, peppermint oil. Well, that's what a lot of my patients think. They think it's kind of crazy. Well, peppermint oil helps relax smooth muscle within the GI tract. In fact, that's actually what IBGARD has if you're treating your patients with IBGARD and over-the-counter IBS treatment. And in this study, they looked at patients that were asked to take 1 to 2 Altoids dissolved in their mouth. And you can see they just asked them, do you feel better, worse, and if so, how much? And patients with distal esophageal spasm, EGJ outflow, which we'll talk about in the set, and hypercontractile esophagus actually had pretty good symptom relief rates. And in my clinical practice, I see a pretty good response. I tell patients this burns no bridges, and worst case scenario, there's no side effect profile, and you just have some good breath. So it's often one of the first lines of treatment that I'll at least try. If I do find a hypercontractile esophagus or distal esophageal spasm, I often jump to their medication list. Just like we know opioids can affect other parts of our intestines, like the stomach and colon, we're learning more and more that opioids also affect the esophagus. And opioids don't just shut down contractions. What they do is they increase aperistaltic contractions. And that's why we see this association with opioids and spastic and obstructive disorders of peristalsis. In this study, they looked at patients that underwent high resolution manometry that were on opioids and those that were not on opioids. And you can see that there was a much higher rate of type 3 achalasia or spastic achalasia that we'll talk about in a second, distal esophageal spasm, and EGJ outflow obstruction. Unfortunately, the treatment really is to try and get these patients off of their narcotics, which is much easier said than done. I think that's something that we can all appreciate. So this is something that we're learning more and more about. And just keep in mind, if your patient is on chronic narcotics, this could be one of the reasons they're having difficulty swallowing. Now that we've reviewed the disorders of peristalsis, or those people that have a normal IRP, I want to jump to the other side of the chart. Those patients that have disorders of EGJ outflow or an abnormal IRP. We'll start by talking about achalasia. I think we all remember seeing this photo from medical school. A patient with a bird's beak esophagus, dilated esophagus. And what achalasia is a reminder, it's this progressive disease due to degeneration of ganglionic cells. People then get impaired relaxation of their LES. They lose peristalsis within their esophageal body. What's really neat is that with high resolution manometry, it's not just do you have achalasia. We are now able to subtype achalasia into 3 different types. Type 1 is that classic finding, lack of peristalsis and impaired relaxation of the LES. With type 2 achalasia, what we see is this pressurization of the esophagus. You can see these bright bars running from the UES down to the LES. These patients actually have the best outcomes. So if we find this, we can tell the patients, you're likely to have a positive response to achalasia treatment, which always is targeted at trying to relieve pressure at the lower esophageal sphincter. And then there's type 3 achalasia, or what we call spastic achalasia. Not only does the LES not open, the esophageal body is spasming. And this historically has been one of the most difficult types of achalasia to treat. And we'll talk about how some advancements are changing that. So historically, laparoscopic Heller myotomy with fundoplication has been the standard treatment for achalasia. That's an open surgery where the surgeon goes in and cuts the valve at the bottom of the esophagus. POMA has been around since around 2010, and it's a novel endoscopic approach to myotomy. The surgeon tunnels through the esophagus, through the submucosa, down to the lower esophageal sphincter and cuts it that way. And I have novel written here because I have a lot of patients that still think this is experimental. They don't want to undergo POMA. It's been around for the last 12 years. Well, I think this is really a seminal paper. This was published in the New England Journal in 2019, where they compared POMA to Heller myotomy. And they found that POMA was non-inferior at 2 weeks follow-up. They, in some subgroup analysis, POEM was actually potentially superior. So I think this really lays to rest that POEM is a experimental treatment, and it really is now the forefront of our treatment for achalasia. And it's not just that POEM is as good as hilar myotomy. There's a lot of pros to it. It's less invasive. People can have a quicker recovery time, and it seems to be a good option for older, higher risk patients. And one of the things is you can extend the myotomy into the esophageal body. We'll talk about that on the next slide. One of the major cons is that they can't do a fundoplication when people are getting a fundoplication. And therefore, these patients are at slightly higher risk of postoperative GERD. Many of these patients will require PPI therapy. So I mentioned type 3 or spastic achalasia has been one of the most difficult to treat. Well, this paper really changed how we look at that. And they looked at patients that had type 3 achalasia that got POEM and hilar myotomy. And they found that the people that got POEM did dramatically better. You can see a response rate of 98% compared to 80% with hilar myotomy. And the main reason for that is that the surgeon could extend that myotomy up into the esophageal body. You can see the length of the myotomy in the POEM group was 16 centimeters compared to only 8. So this is one of the ways that treatment for patients with esophageal motor disorders have really changed with the advent of new treatments like POEM and our ability to subclassify types of achalasia. And I think more of this will come. I want to move on to the last disorder of EGJ outflow called esophagogastric junction outflow obstruction, or EGJ outflow obstruction. Not only is this the bane of my bane of my existence in practice, also was not looking forward to having to say that many times during this talk. But what it is an impaired relaxation of the LES or elevated IRP with intact peristalsis. And the reason that it's kind of the bane of an esophagologist's practice is that prior studies have shown spontaneous resolution in 40 to 72% of cases. How many diseases half the time may just go away? Well, part of it is when they've looked at these studies, they found that 16% of patients had a normalization of their IRP or lower esophageal sphincter opening when they changed patient position, which is why the new Chicago classification has some more specific things required. And that is now an abnormal IRP in the supine and upright position, which is something we've changed in our protocol. But it also requires some abnormal adjunctive testing, really to confirm that this patient really has a problem at their LES. The authors were concerned that we were probably over-treating patients, doing LES targeted therapies when they really didn't have anything clinically significant. So this is an example of a patient that I saw a couple months ago. She's 53 with progressive solid and liquid dysphagia, who's noted to have dysmotility on esophagram. And you can see on the left, the left picture, that swallow looks just like achalasia, but she had 2 swallows that were completely normal. And I was kind of left with, I don't know what to do. This is achalasia. I probably want to be a little bit more aggressive. So this is a patient that I got set up for EndoFlip. EndoFlip is a new technology that we introduced here at UW in March of 2021. And we're really excited about it. This is a device that we do during sedated endoscopy. We remove our camera and place this catheter transorally down into the esophagus. And what we do is we blow up that balloon with water. And that balloon then stimulates secondary peristalsis, or the esophagus's response to distension. And then that balloon measures things like diameter, pressure, and volume. And we get some important metrics. So the first metric we care about is EGJ distensibility. This tells us how well is the LES opening. I think this is the correlate to IRP on manometry. A high distensibility means normal opening, and you can see that here on the right. You guys don't need to know what numbers is normal. And a low distensibility means poor LES opening. And you can see this kind of looks like a person with type 1 achalasia on manometry. And when we compare the distensibility index and diameter to high resolution manometry, it actually performs quite well. On the left, you can see patients that had an abnormal manometry with EGJ outflow. And in the red are the patients that had a low distensibility and low diameter. Almost all those patients fall in there. Conversely, when they looked at patients that had a normal EGJ outflow on their manometry, very few of those patients had an abnormal EndoFlip with low distensibility. Now you can definitely see that there's a gray area, and we're really in the infancy of understanding EndoFlip. The other thing that we're going to measure with EndoFlip is the contractile response, or what does the esophageal body do when we distend it? A normal reaction are these repetitive antegrade contractions, or what we call RACs. But you can see other things. You can see absent contractility. You can see kind of these disordered contractions, or you can see something that's very abnormal called repetitive retrograde contractions. And what's really neat is that when you compare this to someone's manometry, you can see how these look a lot alike. So with my patient, we set her up for endoflip, and what you can see her endoflip on the right. You can see there's really no contractions in her esophageal body here, and her LES does not want to open up. And all of her metrics really fit for opening. So we treated her for Botox, and I sent her for the surgeons. And I actually just found out last night that her Botox treatment really improved her symptoms, and she'd actually canceled her POEM treatment because she feels that much better. But this is just one of the ways that POEM is changing how we treat, or how endoflip is changing how we manage and treat our patients with dysmotility. This is me as a fellow doing manometry. I wanted to know what it felt like. If you've ever had a tube stuck down your nose, you understand that it's very, very uncomfortable. You can ask the nurse that did this. I was a very, very bad patient. But the holy grail of endoflip, is there a way that we can try to eliminate the need for manometry? Can we classify the patient's esophageal motility during their index endoscopy, eliminating the need for additional tests, reduce the time to diagnosis, and maybe even when a patient comes in, we can start therapy right then and there. Rather than, I think we all know what happens when you need to order multiple tests. They come in for an endoscopy. A couple of weeks later, we get them set up for a manometry, and a couple of weeks later, we're starting treatment. Well, and this data all comes out of Northwestern. What the investigators who developed endoflip are trying to do is trying to reclassify esophageal motility according to endoflip. And they're using things like the contractile response and the probability of EGJ obstruction to build this framework. What's pretty obvious from looking at it, the whole box isn't filled in. There's clearly some gray areas that we just don't understand yet. Additionally, using these two metrics, there's this group, the spastic reactive, that just doesn't really fit into their classification scheme. But I think what's really encouraging is that if you look at endoflip and how it performs compared to high resolution manometry, there's some promising data here. When you look at people that had a normal endoflip or a weak finding on endoflip, very, very rarely did they ever find something serious like type 1 achalasia, only one case. Similarly, when patients had obstruction or with a weak contractile response, or what you would expect to see with achalasia, this performed really well. That's almost exactly what all these patients have. So if it's a normal test, really good negative predictive value that manometry is going to have something abnormal. Similarly, if you find something that looks like achalasia, the likelihood that they have achalasia is very, very high. The problem, as I had mentioned before, is there is this group, the spastic reactive or inconclusive group, that it just doesn't fit yet. We just don't have a way to really define hypercontractile or distal esophageal spasm. So I don't think we're quite there yet to have endoflip as its own classification scheme. I think as we understand it more and have more experience with it, it's really only been around a couple of years. I think it's really promising. I didn't include the algorithm that these authors proposed, because at the end of it, almost all the time they said either recommend high resolution manometry or consider as high resolution manometry. And I still think that's still our gold standard at this point. But at the end of the day, what we have in our toolbox in Dysphagia Clinic are all these different tests: esophagram, endoscopy, manometry, and endoflip. These are all complementary. So I always tell patients, we need to gather all this information and let's build this story to figure out what is the best way to treat you. So with that, I'd like to conclude. Just as a reminder, dysphagia is highly prevalent. Just remember, when you're seeing these patients with dysphagia, listen to what they're telling you, because they really do have impairment in their quality of life. If you don't know what to do when you're talking to someone with dysphagia, or you can't figure out whether it's a swallow study or an endoscopy, feel free to send them to our clinic for a dysphagia evaluation. Next, if someone has solid food dysphagia, this is what I tell my medical students: immediately think about obstructive dysphagia. Think about some sort of stricture. These patients are at the highest risk for esophageal food impactions. And if you see someone in clinic that's had a food impaction, make sure they get established in our GI clinic. We want to prevent this from happening again. And lastly, our understanding of esophageal motility continues to evolve. I think endoflip really provides this unique assessment of esophageal motility that we've never had before. And I think there's this potential for endoflip to classify motility at index endoscopy down the road. This is my daughter, Eliza. I tried telling you need to listen to patients and understand and empathize with them. And I do that, but I really didn't have the anxiety and hypervigilance of swallowing until I started watching my 1-year-old daughter start trying to eat solid foods. And now that's something I definitely can appreciate and understand. So with that, I'd like to thank you and open it up to questions.
Great. Thank you, Dr. Hillman, for a wonderful overview of dysphagia. I will say one of my triumphs in my first year as department chair is overseeing the acquisition of the EndoFlip, as Dr. Lucy will, I'm sure, agree with.
Well, thank you so much for that.
I'll ask the first question. So you mentioned the increasing incidence of eosinophilic esophagitis. What is the thought behind why the incidence is increasing?
I don't think we completely understand that. There's a lot of different things where they're looking at genetic predisposition to this. I think I'm not an allergist and I don't pretend to be an allergist. Just like we're seeing a lot of allergies, increase in allergies across all age groups for other things. But we really don't understand the exact pathophysiology of it. And I think that's one of the things that, Dr. Mather in our allergy department is trying to better understand.
Okay, great. Couple of questions. So can you address distinguishing esophageal symptoms from atypical angina and how you approach that?
Yeah, that's a great question. So when someone comes in with atypical chest pain and dysphagia, I actually just saw a patient yesterday in clinic that was labeled as dysphagia, but the more I talked to him, he was having atypical chest pains. So I really try to differentiate. When you're having pain, is it with swallowing or more odynophagia, or is it independent of your eating behaviors? Often if we see someone in clinic that has any risk factors that they've never had a sort of cardiac test, they have diabetes, high blood pressure, they're a male, over the age of 50, former smoker. Before we really want to do anything invasive, we'll often send those patients back to their primary and say, just rule out cardiac disease before we do any sort of invasive testing. The last thing we want to do is put them under anesthesia. But it's really just trying to differentiate, is that pain happening with swallowing and eating, or is it completely independent of that? And I can tell you half the time the patients can't even tell you themselves, which is the tricky part of all this.
Next question about how strong is the evidence for modified diets like thickened liquids, et cetera, in terms of minimizing aspiration risk, especially in the outpatient setting?
That is a great question. And I would say I would have to punt that to my speech pathology colleagues. I know Dr. Gomnitz, one of my colleagues, is really trying to look to see how diet consistency can change esophageal symptoms. But I'm sorry, that is definitely where we work with our speech pathologists who really give them their swallowing techniques.
Okay. And then a pragmatic question. So to get a dysphagia, to get into dysphagia clinic, do you just do a GI consult? Do you do a dysphagia clinic consult? How do we get our primary care patients, for example, into your clinic?
That's a great question. And I had a feeling that question will come up. So there's 3 different ways that you can kind of get in. One, just a dysphagia. If you order a GI consult and say the patient's having dysphagia, that'll get triaged by our nurses and they'll determine if that patient should just be seen in clinic or whether they should get that GI dysphagia evaluation. If you just want the radiology studies, a speech pathology consult and an esophagram, if you just order a GI dysphagia evaluation, then they'll get the radiology studies and they'll come back to you. But if you want them to be seen by the GI provider the same day, it's called GI dysphagia evaluation in HealthLink. And just in the comments say, please have GI consult associated with this or have GI see same day. That's exactly how I order it. And then they get put on my schedule.
Great. And then can you talk about the dysphagia that we see with bulbar ALS?
It's funny that you say that. Again, that's really the reason that you say that is because as a resident, I was seeing a patient in VA clinic down in Chicago, and he kept having workup for like phlegm, GERD, reflux, and no one could figure out what was going on. And he kept having worsening dysphonia. And I'm like, this seems like a neurologic problem. And unfortunately, we ultimately got a neurology where he was diagnosed with bulbar ALS. Again, that's really more in the area of oropharyngeal dysphagia. And I think that would probably be a better question fielded by one of our speech pathologists. So I try to stick to the UES and below, but what I tell my patients in clinic.
That's highly, highly specialized in GI, a narrow segment of the esophagus. So there's not a primary impact on peristalsis of the esophagus, it's primary upper.
So I have not seen bulbar ALS specifically. The first third of the esophagus is is controlled by striated muscle. So sometimes on our esophageal manometries, we will see people where we actually don't see that first third of the contraction. And that will raise our suspicion maybe for some sort of myopathy or neurologic disease. I can tell you it's very, very rare because those people typically also are going to have like corresponding oropharyngeal dysphagia. And then they never really make it to our clinic because they're getting worked up for some other neurologic condition on top of that. But that can be a sign. So I think maybe once or twice I've seen that, and I've sent someone to rheumatology clinic to work up for some sort of myopathy.
Okay. There's also a comment from Jill Zielinski commenting that the VA also has a dysphagia specific clinic, a multidisciplinary clinic. So if you're got our VA patients, we can send them there. So thank you. And a number of comments just acknowledging what an outstanding talk you've given.
Thank you.
Great work. Thank you, everybody. I want to put a reminder that Department of Medicine Town Hall is next Wednesday. We have actually two really impactful presentations. Shiva Bidar-Shalaf is going to be coming and talking about the plan for DEI efforts across our systems. And then Bob Flannery, the CFO from UW Health, is going to be presenting what the current financial status at UW Health is, as well as our COVID update. So I hope everybody is able to come to the town hall next week. And with that, thank you everybody for your attention. Stay warm, stay safe.